All right, awesome. So we are recording and ready. Again, hi everybody. Thanks for joining us this morning. My name is Lee Storo, Executive Director of North Carolina AIDS Action Network. I'm going to ask folks if you've got background noise or really just in general to keep yourself muted throughout the conversation. I think as we all know, that always helps sort of make things easier for folks to see and be on with us. Today's topic is about some pretty exciting changes to our state's HIV Medication Assistance Program. That is the AIDS Drug Assistance Program of North Carolina for folks who may be out of state or not familiar with that nomenclature. NCAN, the North Carolina AIDS Action Network, has always had a strong focus on our state's HIV Medication Assistance Program and ensuring that program was fully funded and well supported. In many ways, we were founded in 2010 out of a bit of a crisis for our state's HIV Medication Assistance Program when we had one of the longest waiting lists in the country and some of the tightest eligibility standards. Since then, our program has been really successful and been a really significant player in terms of allowing folks living with HIV to have access to the medication that they needed. In 2016, we led an effort at the North Carolina General Assembly to change state law to allow our state's HIV Medication Assistance Program to cover premiums for individuals on the program who purchase their own health insurance on the exchange or through other mechanisms. In a lot of ways, North Carolina has been a beat behind our contemporaries and states around the country on that front. Many states, including South Carolina, Virginia, and Tennessee, have had programs in place for much longer than us that covered health insurance premiums for folks on the program. So in 2016, we were able to change state law to allow premiums to be covered. There was a small program in place prior to that Aldona Voss, when she was Secretary of Department of Health and Human Services, was able to get through administratively that covered co-payments. But it was certainly really thrilling for us to have state law change to allow for full access to premiums to be covered through state funds. So it has been a bit of a slow road for that program to be implemented. Over the last several years, that program has been in place and allowed some individuals to receive assistance, but not everyone. And as we're going to hear, particularly from Deetra, but through our conversation today, there's a really exciting and really significant change that's going to allow that program to basically cover any US resident who's enrolled in the program, who enrolls during open enrollment this year. This is a really critical moment, I personally believe, for the HIV advocacy movement in the state, and really think that we need to harness, as much of our energy and passion and work as we can to make sure our community really gets access to this program. So with that being said, I'm going to pass things off to our first speaker. As I think I alluded to a second ago, our first speaker is Deetra Purcell, who is the HIV Medication Assistance Program Coordinator with the Communicable Disease Branch in the Division of Public Health. Deetra and her team always do amazing work, but I know are particularly stepping up their energy and passion and dedication to roll out this program in the coming weeks and coming months. So Deetra, with that, I will pass it off to you. Deetra is just joining us by audio today, so I'm going to do my best to keep my slides in queue with her presentation, but please forgive if we're a beat off or anything like that. So Deetra, I will pass it to you, and thanks for being with us today.
Thank you, Lee. Thank you for a warm introduction. And yes, you are absolutely correct that our energy is really in high gear with the changes that we're making to the program. So I want to say good morning to everyone. And I do want to talk about all the good things that are happening in the HMAP camp or world. But I'm going to just start off with giving just a brief background of HMAP, and it's about 5 slides that are just pretty much focused on the overall program, and then we're going to hone in on all the exciting things that Lee described. So slide 2. So I just, like I said, want to give a brief introduction and overview of the program. And HMAP receives both state and federal funds to provide medication and health insurance premiums, co-payment assistance to clients of low income that are residents of North Carolina, so that they can have access to essential life-saving medications for the treatment of their HIV and all the related conditions or other comorbidities, and also for the prevention and treatment of related opportunistic infections. Okay, we can move it forward. So the eligibility criteria to receive HMAP services are obviously that the person has to be HIV positive, they must be a North Carolina resident, and must meet the modified adjusted gross family income that is equal to or less than 300% of the federal poverty level. Next slide. So under the HMAP umbrella, there are 4 sub-programs, and those sub-programs are UMAP, which is our uninsured and underinsured medication assistance program, and then we have SPAP, which is our state pharmaceutical assistance program, and ICAP, which is the insurance co-payment assistance program, and PCAP, the premium and co-payment assistance program. Next slide. So I want to just explain each of those sub-programs briefly. UMAP is pretty much HMAP purchases the medications directly from a contracted pharmaceutical wholesaler, which is Cardinal, and we distribute the medications through our contracted dispensing pharmacy, which is currently Walgreens. And for SPAP, we use a pharmacy benefits manager, which is currently Ramsdale, to coordinate with Medicare prescription drug plans to pay all of the out-of-pocket costs for any medications covered by the primary Medicare prescription drug plan, which is either Medicare Part D or the Medicare Advantage plan. Next slide. And then just a brief description of ICAP and PCAP. ICAP also uses the Ramsdale to coordinate with qualified health plans purchased on the federal marketplace to pay all out-of-pocket costs for any medications covered by the primary qualified health plan. And PCAP also uses Ramsdale to coordinate with the QHPs purchased on the federal marketplace to pay all out-of-pocket costs for any medications covered by the primary qualified health plan, as well as their monthly insurance premiums. And so we're going to really focus on PCAP because that's where the biggest change has occurred in the program. And so for the rest of the talk or discussion, the main focus is going to be PCAP. Okay, next slide. So as we mentioned, I'm going to talk about the big news, which is our PCAP expansion of our program and that we're implementing and it's underway as we speak. I want to talk about what the differences are actually. And so historically, PCAP only paid premiums for clients with incomes that were 100% to 300% of the federal poverty level. And so the branch, and we really took a very microscopic view and did some careful calculations of available funds. And we thought about how we were going to expand PCAP and how we would ensure that in doing so that we would stay in compliance with federal and state regulations. And we saw that we could actually, based on our calculations and based on the rules and regulations that guide the program, that we could in fact expand PCAP and pay all of the monthly health insurance premiums, deductibles, and medication co-payments for all HMAP clients from 0% to 300% FPL, with the caveat, which is most important, that they enroll in the Affordable Care Act marketplace coverage in order to be in PCAP. Next slide, please. So here's where we are now with the changes we've made. All of our HMAP clients will be eligible for PCAP. That's the key, if they are a U.S. resident. Now, the U.S. residence component or requirement is an Affordable Care Act requirement and is not an HMAP requirement. But because, of course, being a part of the enrolling into an Affordable Care Act plan, the citizens would have to, in fact, be a U.S. resident, and it's no way around that because of the law. And it is unlikely that clients should need to change to a new medical provider if they enroll into the ACA. So hopefully there wouldn't be any problems with that, and they would be able to continue to see the same doctor. And HMAP has already started making calls to clients, and we are looking to call, over 6,000 clients that are in the UMAP program. to discuss marketplace insurance with them and to help them understand the benefits of having the health insurance coverage for not just their HIV care, but for their whole health care. And so in these calls, we're letting them know when the enrollment time is, which is November 1st through December 15th. And if they enroll during this time period, the ACA coverage would become effective in January 1 of 2021. Next slide. So there are also some things I need to point out with PCAP that has not changed. So some of the eligibility criteria that is remaining the same would be that clients would not be able to enroll if they are a non-U.S. citizen due to the Affordable Care Act rules. So the HMAP clients that we have who are not U.S. citizens will remain in their existing HMAP sub-program, which is UMAP. And all members on a family plan must be HIV positive in order to be on the PCAP covered insurance. So the only way people that are living with HIV can be insured through PCAP is if they enroll into their own individual plans. Okay, next slide. So ultimately with this expansion, HMAP want to move as many people from UMAP to PCAP as possible during this enrollment period. We recognize that there's benefits for our clients, and we want to help our clients recognize the benefits from them moving from UMAP to PCAP because they can get treatment for other diagnosed medical conditions, and they will also have access to medications that are not on the HMAP formulary. Next slide, please. So here we've outlined action steps that we're going to take in coordination with the case managers, providers, and NCAN to see this expansion through. Case managers and HMAP staff, again, are reaching out to over 6,000 UMAP clients. We are encouraging them to enroll in marketplace insurance through the HMAP PCAP program during the enrollment period of November 1 through December 15. And during these calls, we are stressing the importance and the benefits in obtaining health insurance coverage for their overall wellness and health care. And we're emphasizing that new health insurance will cover all medical conditions and not just their HIV. Okay, next slide. So there will be some challenges along the way with the expansion. What we do know is that clients that do enroll in the ACA will still have to pay a copayment for non-HIV medical visits, and they may not have the resources to do so. What we do know also is that if clients access Ryan White services for Ryan White Part A and B, their outpatient ambulatory visits can be covered through this part of the grant. And Ryan White Parts A and B are the payer of last resort. So after others' resources are sought and utilized, whatever is left in the gap, Ryan White will take care of that. But also, the eligibility criteria in Ryan White Part A and B, I'm sorry, not criteria, but there is a service line called Health Insurance and Premium Cost Sharing. We call it HIPSCA for short. And that can also be used as some gap coverage for some medical visit copays. And we are working internally at the state level to try to discuss how this is going to really be implemented and so the case managers can utilize this as a source or resource to assist their clients. And we also are still encouraging case managers to assist clients with finding sources to assist with medical visits in addition to Ryan White as for their medical visit copayments as they presumably do now. Okay, next slide. So one of the important pieces to enrolling in the ACA through PCAP are the PCAP binder payments. So essentially the binder payment is the first month's premium payment. And once the client is enrolled, the ACA will send the plan information to the insurance company. And so the insurance company will also send the client a bill. And the client must make sure, what we're stressing on these calls is to get your bill to the case manager. And the case manager in turn will coordinate and get the bill to the HMAP office for us to make that binder payment. It is key to, as we've been having talks through different webinars and conference calls with case managers, that the binder payment documents must be received by HMAP office by December 22nd in order to ensure that clients' premiums are paid by December 31st so that their coverage can start effectively January 1st. Next slide. So some of the educational efforts that are already happening in the community around expansion, we've created an English and Spanish version of the PCAP announcement, and it has gone out for distribution. And clients that fill their prescriptions at Walgreens can expect to see an informational in their prescription bag or that flyer describing the PCAP expansion and enrollment information. Clients are also hearing from HMAP staff, and these same clients will hear from case managers about enrolling in the ACA and about eligibility for PCAP. And so we're looking to work with NCAN on special messaging about the expansion on various social media platforms and other public educational outreach, that any ideas that we have or that we glean from others along the way, we can discuss putting those things in place as well, because we want to get the information out as widespread as possible. So next slide. So I want to thank you, Lee, and I want to thank NCAN for giving us the opportunity to speak on the program and the expansion efforts that are underway. And if anyone has any questions right now, we're open for questions. And if you think of anything later, you can always reach, you can reach me, you can reach Natalie Gupton, who is our ICAP, PCAP coordinator, or you can reach out to Nicole Fields-Pierre, who is our UMAP coordinator, who's really working closely with Natalie on this process, because, of course, the idea is to get as many of the clients under UMAP into PCAP. So that's all I have presentation-wise, and if you have any questions, please feel free to ask.
Deetra, it looks like we had 2 questions in the chat that are a little technical and specific, so I think I'm going to go ahead and ask you now before we move to Mark. The first question is, how soon after enrollment do clients receive the bill for the binder payment? I could see that someone enrolling toward the end of open enrollment will have a very tight turnaround on that.
Oh, so I don't know how long it takes for the company to process all that information and send the bill. I'm not sure. Sometimes it can be viewed online once the client has signed up. I will have
I can answer that, Deetra. This is Mark from the Navigator Consortium. They will be able to see that binder payment bill immediately upon enrollment. They will also get a hard copy of that bill in the mail, but they will get it immediately upon enrollment. Folks actually have the option of making a binder payment when they actually enroll, but they will get a copy of that can be printed and taken with them upon enrollment in an ACA plan, in a marketplace plan.
Thank you, Mark.
And then the next question is, if someone were to qualify for a special enrollment period and can get insurance prior to January 1, would PCAP pay, or would you like to focus solely on the open enrollment period?
So when we were on a call on yesterday, I think that came up. I do believe that we would still be able to assist clients if they have to do it during the special enrollment period. I will confirm that, though, with Natalie, just to make sure, and I can get that answer back to you, to Lee, to get back to the participants. But I do believe so.
Gotcha. And it sounds like it's a similar question that came in. When would a client be enrolled in ICAP where you're only having your medication co-payments paid for versus PCAP, where the premiums and medications are being both covered?
So from what I understand, so there's some clients that are on ICAP that are not wanting to enroll in PCAP because they are fine with paying their own monthly premiums and they like the way everything is working now. But ICAP clients are also eligible for PCAP. We just haven't taken ICAP off the table as an option. So I hope that answers the question. Can you repeat the question again, just so I'm not sure?
Let me, Siobhan, did that answer the question? I mean, I think from my perspective, as an advocacy community, I think the long-term goal of moving as many people from ICAP to PCAP would be a priority of ours, just to weigh in from my perspective. But yeah, Siobhan.
Yeah, I agree.
And that's how we started.
Oh, sorry, Deetra. I think we've seen in the program's current operation, we've submitted applications for clients for PCAP. And when their HMAP application is completed, they've been enrolled in ICAP instead. And I just don't know what the factor is in that decision making on the state's end.
That's something I'll look into because I do. So, and this was pre-expansion, obviously, before expansion?
Yes. Yeah. So right now, there are some clients where, submitted thinking they would be in the PCAP program, and then they're in ICAP.
So I wonder if it could be a number of things. That would be something I would have to look at, like on an individual basis. I don't know if all the documentation for PCAP, and I'm assuming all the documentation for PCAP was included. So I don't know. I will look into that more because I'm certain that we would not just put a person that is intended for PCAP in ICAP unless there is something that has occurred that wouldn't allow us to complete the PCAP enrollment process. But I will look into that.
Okay, thank you.
I'm seeing a couple more questions come into the chat, and I think some of them will be answered by Mark's presentation. So I'm going to go ahead and shift us to Mark, and folks who've asked questions, we'll definitely circle back at the end. So I will go ahead and pass things off to Mark. Mark has been a presenter with NCA Network, actually on this topic for a number of years now. Prior to sort of the restrictions being lifted this year when treatment assistance was available for folks who made between 100% to 300% of the poverty level, we did certainly work to activate and get as many people enrolled in that program, and the Navigator Consortium was a close partner with that. Mark does head up the North Carolina Navigator Consortium. This is the statewide coalition housed within Legal Aid of North Carolina that focuses on getting as many people enrolled as possible during the Affordable Care Act and insurance as we can. So Mark, I will pass it to you to speak next.
Thanks, Lee. Appreciate it. And let me start off by saying I'm so sorry that I'm so close to the screen. I don't have any slides, so and my computer is not working today, so I'm coming to you from my phone app on Zoom. So I feel like I'm real up close and personal with all of you all today. And thanks to Deetra for presenting on some of that information there. I will really underscore this binder payment issue before I start. The binder payment does have to be paid on time in order for that coverage to kick in on January 1st. They are very inflexible about that. at the insurers. So it is critical that these binder payment bills be printed off when the actual enrollment takes place. We know right now there is some delays with mail issues, so I would not try to wait until a hard copy of that comes in through the mail. So with that being said, I just want to say that we are super excited to be able to assist with this program and be able to help you all help the patients and clients that you work with each and every day to get enrolled in an ACA marketplace plan. We have been doing this since 2013 as the Navigator Consortium across the state. And we are in all 100 counties across the state. We really are excited about the opportunity to really bring this to a new community of folks who could really use the peace of mind and the comfort of having high quality health care that is made super affordable by this plan. Our navigators are prepared across the state to assist you all in helping to enroll folks. I'd love for them to start making relationships with you guys across the state. We have certain areas of the state where we're really going to be able to hyper focus on this work, as we have particular people funded just specifically to do this enrollment work. In Greensboro, I can think of right now, thanks to the support of Code Health Foundation, we're going to have a person that's dedicated only to this work, which is super exciting. But across the state, we've been talking to our navigators and creating a plan to make sure that they become experts in this as much as possible and are giving the best advice to your clients and your patients as possible when they are enrolling. So we will help them to find plans that work with the doctors that they're currently seeing, that make sure those doctors are in network. We will look for the formularies. We'll look through the formularies and make sure everything is covered there, both their HIV medications and other medications that they may need to take. And we will help them to find the best plan for them. We will do that hopefully in coordination with a lot of the case managers across the state. What we are in the middle of doing right now is preparing flyers and some marketing materials that we will send out to folks. I think probably we'll send those out through Lee and then get those to folks, or I will leave my information in the chat box and folks can email me directly if they have any questions or would like us to send materials directly to them. But we will send out marketing materials that specifically address this population and how they can get assisted. It's probably easiest for the case managers, if they are working with certain clients or patients, to schedule appointments directly with our navigators to help them enroll. The case managers may feel like they can enroll folks on their own. And if they feel comfortable with doing that, that's great. I will say we have a lot of experience with the application and know these networks and formularies inside and out. We go to extensive trainings with each of the providers, our insurance providers, each year. Those are actually next week for our folks, where we really learn the ins and outs of every single plan that's on the marketplace in North Carolina. So I would encourage you guys to have the case managers kind of work directly with our navigators across the state. And have a relationship with those folks. So you can do warm handoffs back and forth. You can have remote appointments for enrollment if the consumer approves with a case manager and the client on the phone. This should really be a relationship where we all kind of work together to make sure that we are addressing each and every patient's specific needs and making sure that we are checking all those boxes when we do enroll those folks in a marketplace plan. But we are very excited about this. I will say one thing about Dietrich's presentation, and I'm not sure if the state wants this or not, but you do not, for the marketplace, you do not have to be a U.S. citizen. You have to just be a legally documented resident. So I don't know if that makes any changes to the program, but I just wanted to say that you just have to be a legally documented resident to be a marketplace, to get marketplace coverage. You do not have to be a citizen, just legal documented. But we are super excited to help you all. And to get folks coverage. I'm again going to leave my information in the chat box. I'm happy to take any questions now, but we are also new to this. So as there are things that you feel that we need to know, if you see some of the marketing materials and you feel like we can address certain things better, or we need to highlight certain facts more, we are certainly happy to do so. We love some critiques, and we love to know how we can do our jobs better, especially when we're talking about certain specific populations of folks that we may not have worked with so closely before, but we, like I said, are certainly excited to do so now. So that's really all I have for now. Again, we will get these marketing materials out to you all. I'm going to put my information in the box. You can let me know directly, or I will send them to Lee and he can disseminate those as well.
Awesome. Thanks, Mark. And if I could just sort of, I think, you know, many of us on this conversation know why this change and opportunity is so important, but I think just to even take a step back and look at some of the data on this front, there is really compelling information across the country, including in our own backyard, that shows that when folks living with HIV, particularly folks eligible for these programs, are able to transition from just receiving free medication through programs like HMAP and ADAP to full health insurance, that they get better health outcomes and they get better viral suppression rates. When we helped pass this law in North Carolina in 2016, Virginia had recently done a study about its ADAP program that showed that folks who were on Obamacare insurance through the exchange had significantly better viral suppression rates than folks who were just receiving HIV medication. And that's also true in the data that we have from our own program for the last couple of years. About 400 people have been able in these first couple of years to transition onto the program, onto the PCAP program, and receive their health insurance subsidized. And those folks have better viral suppression rates by about 10 points than folks on UMAP. We're lucky that everyone on the HMAP program has really high viral suppression rates, especially compared to folks off the program. Our partners in DTRA and the state government have done an excellent job, but this opportunity really does let us level up this work. You know, NCAN has been engaged in conversations for several years, which many of you all have been involved in, about how we imagine what it means to end the HIV epidemic in our state. And moving thousands of people to full health insurance and achieving better viral suppression rates, I mean, that's one of these policy wins that absolutely does that. It is true that as more people achieve viral suppression in our state, we are going to stop the transmission of HIV to other individuals. So this really can be a game changer. It's something that's probably going to take multiple years. We're probably not going to move everybody onto the program right now. You know, and as Dietrich alluded to, there may be some individuals who, for one reason or another, that they're receiving other assistance, it might not make sense to move right away. But we really are committed to making sure everyone has as much information and all the options to best understand how they can benefit from this program. The last thing I'm going to say is that, you know, this program was made possible in many ways by the passage of the Affordable Care Act, right? The creation of the marketplace wouldn't have even existed without the passage of Obamacare. I think many folks know that we are at a new place and time in this country related to that law with this recent Supreme Court vacancy. We took a deep dive into it on our webinar last week. If folks want to talk offline or look at that recording on our YouTube page, feel free to. But I do think there are some real concerns about the future of the Affordable Care Act that are just a little bit unique and different within the last couple of weeks with the passage of Ruth Bader Ginsburg and with the appointment of a nominee who really has a really negative record when it comes to the Affordable Care Act. That being said, that should not stop our efforts to get as many people enrolled this year as we can. I think there's some confusion that there is inevitability about the end of the Affordable Care Act, or, if Judge Barrett was appointed, that it could happen overnight, and that is simply not true. So our community and our network is going to be very active in opposing her nomination and in speaking out about the benefits of the Affordable Care Act. But please don't let that rhetoric get confused about the real necessity of getting as many people enrolled as we can. And look, if something were to happen long-term, getting as many people taking advantage of the law, taking advantage of health insurance in 2021 as we can is still going to make a significant improvement for the health of our state. I am sure we know people living with HIV who have been waiting to do certain surgeries or certain procedures because they were saving up money or didn't have access to insurance. It should be our goal to get those folks into insurance, and help them get better other health outcomes in 2021, really, if we can. So let me take a look. I've seen we've had several questions come through the chat.
And while you take a look, Lee, I'd just like to say, to add to that, folks that do enroll, no matter what the decision is, that hearing in front of the Supreme Court is scheduled for November 10th. We probably will not get a decision until May or even June. And folks that are enrolled in the plan will be enrolled in the plan will be grandfathered in no matter what the decision is for the remainder of that plan year. So they will not taking away coverage at that immediate moment. The consumer is in a contract with a insurance company and the federal government, really, with the subsidies that the federal government pays. So they will not be taking this coverage out immediately if the decision is to strike down the Affordable Care Act. Also, the decision in front of the court right now is really regarding the mandate. So there's a lot that's unknown. And so it's very important that the message be spread that the Affordable Care Act is still the law of the land, and that folks can still enroll, that folks are still able to, get everything that they were able to prior to with marketplace coverage. So I think that's critically important because there's a lot of folks that already think the Affordable Care Act is gone, and there are a lot of folks who in the next 40 days or so and all the way up till November 10th and then beyond are going to they're going to be pushing the narrative that the Affordable Care Act is gone and trying to spread some information to confuse people. So it's really important that we all know that and we're all able to share that message as well.
I've seen we have sort of just a couple questions about, resources about helping folks make decisions and getting out the word. The last thing I'm going to note before we open it up to Q&A, NC/AIDS Action Network is really committed to doing all we can to get the word out to our community in as many ways as possible. Folks have likely seen that a couple weeks ago, we put out an open call for mini grants to support creative efforts and local enrollment. We have had a little interest in that already. If I could ask Dante on our staff, he's going to drop the link into the chat that has the information to that mini grant program. But we had sort of two goals with this program. One, we did want to sort of inspire and increase energy around this within our movement. We know a lot of organizations are uniquely cash strapped right now with COVID and some of the other challenges around that front. And we also know that some of y'all working in ASOs, working in local clinics, may be best primed to do creative local efforts to directly reach the folks you're serving. So in all seriousness, please be in touch with us if you have ideas. That application is fairly simple. It's 3 questions. We're interested in knowing what your ideas are and specifically how you're going to reach, those most impacted by HIV and communities of color in this work, and a budget. It's not a ton of money, but we're really hoping to be able to infuse quickly and rapidly some funds to help support creative enrollment efforts, especially knowing how fast the turnaround on this is. So Dante just dropped the link into the chat. If you have questions or want to talk about that, please feel free to reach out to him. His email address is Dante, DONTE, @ncan.org, and that contact information is in that link as well. So a couple questions that have popped up. We have a question about binder payments. and excuse me, my something just popped up on my screen. So the question is that are binder payments able to be paid via debit card or credit card, or do they have to be mailed? And so there's a worry about how slow the mail can be. Deetra, I know you and I had some conversation about binder payments. Any just thoughts on the logistics of that?
So we pay our binder payments through, we use a P card, which is similar to a debit card. We actually go in and pay those individually. And also, we also work with our pharmacy benefits manager to get binder payments paid, and they do still use the mail. But I think, you know, well, I don't know about the mail in terms of like the how delayed it could be. I'm hoping that, well, I think they overnight it. I can make sure that I'm pretty sure that in instances where we are pressing for time, those payments that are paid by mail are done through overnight mail and not just regular snail mail.
Awesome. And then did have a question just in general for you, Mark. If case managers or clinics want to collaborate with navigators, what's the best way to sort of identify partners and find local navigators?
Yeah, if you just want to reach out to me, I dropped my information in the chat box there. You can shoot me an email or give me a call. I'm often on the phone and my voicemail fills up fast, so probably the best way to reach me is by email. And I can connect you with the navigators in your local area, no problem.
And then I know we had some conversation in the chat just about really understanding sort of finances, and want to reiterate. So really for most clients, there really should be minimal cost to them to enroll in this program. The HMAP program will be paying clients premiums and medication co-payments. So the only thing they may be on the hook with are medical visit co-pays, but your Ryan White program should be able to potentially cover that locally. You know, I know for many folks, particularly given the community we're serving, if you are used to being on UMAP and that's working, this jump can feel a little intimidating. It can feel scary. And I think there are really real reasons for that. So making sure folks have the best information and complete information is, I know, really, really important. And then I think there was some general conversation just about the type of plans out there and making sure both, you know, current medical providers and your medications are covered. I'll give a shout out. Many of y'all know my colleague, Allison Rice at Duke Law. They've done a good amount of work over the years, looking at the different plans in North Carolina. There are a couple new insurance providers that are going to be operating in the state this year, and I know they are looking to do some analysis on that. So certainly, you know, as that work is done, we'll be providing resources as best we can. And then Allison actually also flagged on that question about, you know, costs, if there are, because there's out-of-pocket maximums, so eventually medical visits will be covered without cost because of the funds from HMAP going toward your out-of-pocket maximum. So I think most of the questions in the chat have been answered. If I missed something in the chat, feel free to drop it. If folks want to ask a question over audio, you know, feel free to unmute yourself and ask as well. Also, certainly open, just welcome comments and thoughts. I know a number of y'all on this call, you know, are interested in this topic, have worked with us on this topic. So welcome your comments, feedback, and questions.
I just have a real quick question. This is Annie with Triad Health Project. About the application process. If they are currently up to date with their UMAP application, do we need to do a whole new application for PCAP or just send in the information about the plan that they're enrolling?
You would not have to do a new application. You would do exactly what you just said, just send in the updated information that's required for PCAP. We would switch them in-house.
Great, but then still need a January or a new enrollment period reauthorization in January, correct?
Yeah.
Great,
That's
thank you.
all, yeah, all of, yes, that's correct.
Yes, I have a question. Deetra, this is your good friend Christopher out in Western North Carolina. God bless you. You're my angel on earth. We haven't spoken or seen each other in a very long time. I'm currently the GCAB member. Yeah, Christopher.
How you
I lost your
doing?
number the last time. I'm doing the best I can, and I hope to see you at some point in the future. Just wanted to let you know that I've been in 3 cure study clinical 1 phase trials at UNC. Those all stopped, of course, in COVID, so I'm not in one this year. But I am serving as the global CAB representative for the AIDS Clinical Trials Group on behalf of Chapel Hill. So, things are going well. I had a question.
Awesome.
Since I'm currently in HMAP, with Medicare AB and a Part D program. What would I need to do, and what information should I give our local CAP members so they can be aware of the PCAP program as well as others?
I would say, we have some information. We have some information on all of our sub-programs that we really need to combine in one nice pamphlet. But if you are asking about, giving out information on the PCAP expansion, we do have a flyer, that same flyer that is going to be put in the prescription bags with the client prescriptions could be used as informational. So are you saying just specific to the changes that are being made, or just in HMAP overall?
Well, I mean, in the changes as well as HMAP, but as you know, I was doing Walgreens, but it was an hour one way, just to go monthly to pick up my medicine. So I have switched to Chapel Hill's pharmacy, and when I switched to Chapel Hill's pharmacy, I am being charged, co-pays on some drugs, but not for Biktarvy. So I'm not doing Walgreens anymore. It's directly through UNC.
Okay. So what I will do, so I need to make sure if our list service is comprehensive as it needs to be, so that we can make sure that at any pharmacy that any of our clients, regardless of sub-programs, access, that they can still have access to any updates and information. So I will look into making sure that we have a comprehensive listserv that includes maybe that pharmacy contact as well.
Okay. I can send that to you via email since I have your email.
And then, of course, there's our the HMAP website that has our manual and all and it's written in a pretty easy to read way too. So we have all of our forms and our manual on the website. Okay.
All right. That'd be awesome. I know for Chapel Hill, and they serve all of Raleigh and, where you guys are, it's UNC Shared Pharmacy Services in Raleigh.
Okay.
And so it's great to reconnect. Mark, I appreciate all that you do. And Lee, thank you very much for having this meeting. It's extremely helpful.
Hey, this is Allison Rice. Hey, everybody. I just wanted to clarify one thing. And when Christopher first started talking, I think he mentioned something about Medicare. And I just want to make sure everybody understands that people that are on Medicare this is not for them or eligible for them. They would just stay on SPAP. And I find that when I talk about this, people do get confused about that. And so they just need to understand that this is only for people who are eligible for Obamacare plans. And if you already have insurance through a job or through Medicare, this isn't for you. You just keep doing what you're doing.
Okay, great. I appreciate it, Allison. Stay well.
You too.
I saw Kara McGee had her hand raised to ask a question. So Kara, let's pass it to you next.
Hey, thanks. I think Brian mentioned this earlier in the chat. I have a lot of patients who over the years have gone in and looked at ACA plans and they see the cost and it's like, I cannot do this. And so that sort of background, I think, is important to think about how we're, I don't know what any of the flyers look like or anything like that, but I think having something that says, no cost, very little cost, something like that would be an important piece of it, just because I think of people's past experiences of going into the exchange and getting overwhelmed when they see the dollar signs come up.
Yeah, and that's something that we are certainly extremely used to doing. That is a part of our messaging, and has been to every population since we started this in 2013. The tax credits make it affordable for folks. 9 out of 10 North Carolinians that are enrolled now that are receiving some sort of tax credit. So we're very used to adding that into all of our marketing materials and all of our conversations. So we certainly would focus these materials on the financial assistance piece, the low to no cost piece through HMAP. We certainly are doing that, and we'll make that a part of every conversation that we have as well.
Yes, and the HMAP flyers definitely highlight the fact that we are paying, that the clients will not have to pay for their premiums at all. They will have zero cost for their premiums and their medication copays.
Thank you so much.
Mm-hmm.
Any final questions? We're getting close to 11 o'clock, but have just a couple more questions, or have a couple more minutes if people have other thoughts they want to share, clarifying questions or comments for the group.
I just want to say one thing. From having looked at these plans over the years and assuming things will continue more or less the same way, that for people, I think the really most important thing for people is to make sure their provider is in network, because there are a few big health systems that have, jumped back and forth between different insurance companies. And that's, I think, really the only thing that the main thing to worry about. When we've looked at these plans over the years, almost all of the HIV medications have been covered. And the only real difference is like how expensive they are, like what tier they're on. And so that isn't an issue because ADAP is paying for it, HMAP is paying for it. That's their problem. So I think really provider network is really the main thing that people need to really pay attention to. Make sure their doctor is in network.
I agree, and we do that. And I can just tell you that the Navigator Consortium, all of our navigators across the state are very well versed in doing that. That's one of the things that we spend a large chunk of the time that we spend with a client or consumer on. If they have doctors and specialists and all those things that they are used to going to, and they have a relationship, we will work hard to make sure that we find one that has those providers in network.
That's why we think people should use you guys. You know what? You really know this stuff better than anybody.
We've been doing it for a little while.
Great. Well, we are getting pretty close to 11 o'clock, so I'm going to just wrap up with a couple of final comments. We are going to post this recording to our YouTube channel. It will be posted by 5 p.m. today. So if you want to share this with folks within your organization or network or community, feel free to do that. We'll also email out to everyone who registered a copy of Dietra's slides as well. Again, we think this is a phenomenal opportunity for our movement and something that really we need to harness our energy around as much as we can. So please do seriously consider, if your clinic or a nonprofit organization or ASO has some ideas about innovative ways to support enrollment, please be in touch or apply for that mini grant funding. The last thing I will flag is that we do have our annual conference coming up in the middle of November. Historically, of course, that's been an in-person event, and we are hosting that digitally this year, like many organizations. Going to be 2 half days on Friday and Saturday in middle of November, November 13th and 14th. Dante's going to drop the link to that in the chat as well for registration. This will certainly be a topic of conversation during that conference. It's going to be in the middle of open enrollment. We will have some sense possibly of what the world's going to look like in terms of our elections and what our advocacy work's going to look like. Although I'm on a drumbeat of managing everyone's expectations, let's not assume election results will happen on election night, that it's important that we as a community be prepared for all ballots to be counted and whatnot on a tangent and a side note. But do hope folks will plan to think about joining us are asking folks as you can to try to register by October 15th for that. And if you do, we're incentivizing it that we're going to be mailing you a swag bag that you might have traditionally received at a normal conference in the mail, that you will receive shortly before conference, but only if you register by October 15th. So I want to put that incentive out there. I would say the last thing I would say on this front is just please be in touch with us, to Dante or myself, any ideas or thoughts you have in general about this effort, about things we can do to support outside of the mini grant programming. We are looking to host a couple more webinars on this front, have a couple individuals who have been enrolled in the PCAP program who fell within the financial income eligibility standards before this year, who we're going to have on a future webinar speak about their experience being enrolled in health insurance, which I think is going to be really powerful, provide a chance for folks eligible to hear, you know, the benefits and what that experience was like. If you have folks within your clinic or community health center who have been enrolled in PCAP, who you think might be interested in sharing their story in some way, absolutely, as appropriate, you know, be in touch with us about that. We're certainly willing to help, you know, provide an honorarium or speaker fees to folks who might be willing to share their story. Absolutely believe that people living with HIV, that their story and experience has value, and want to recognize that in activities we might engage in. So with that being said, this was a really rich hour. I want to thank Deetra and Mark for their time. I feel really great about the partners we have at the table ready to work on this effort this fall. So be on the lookout for a follow-up email from us. We're excited to work with our community to make this happen, and everybody have a good day and enjoy the week. Thanks so much.
Thanks, y'all.
Thank you.